Okay, I'm actually excited about this tutorial because it's so clinical, like it's stuff that you see on blood tests and go, ooh, relevant or not relevant, isn't it? So does anybody have any cases they can think of that they want to talk about? Probably so many, but if we could just move through, like start with sodium and then move on to potassium and calcium. Yeah. Okay, we're not doing acid base. Nobody asked me any acid base questions, okay? I need to revise that a minute before I talk about it. Okay, so let's start with sodium. Can anyone think of a case where they've sort of thought like, oh, is this hyponatremia significant or not?
I've had cases of DKA when they get really hyponatremic.
Yeah.
But actually, the last one I had when I deep dived on it, you didn't necessarily have to correct the hyponatremia. They almost have a pseudo hyponatremia because how hyper osmolar they are from having really high glucose.
Yes.
Essentially retaining free water to balance out their plasma osmolarity.
Yeah.
So actually, once you correct their hyper osmolar state and bring the glucose down, the sodium corrects itself quite quickly. So you don't necessarily have to worry about supplementing them, or the fluid choices to rehydrate and bring the glucose down is more important.
Excellent. Yeah, perfect. So hyponatremia, and I'm going to give you guys like a system of kind of thinking about it. If you've got low sodium on bloods, I want you to think about what's the osmolality in this patient. Do we have a normal osmolality? Do we have hyperosmolality? Or do we have hypoosmolality? Because then you can look at your differentials, like your differentials are different for each of those. So the one Helen's just mentioned is this patient is trying to correct that hyperosmolality caused by the hyperglycemia, right? So we should have a low, if glucose goes up, sodium should go down to balance that osmolality. If you can't get glucose down, something else has to go down. So it's not until they get really, really dehydrated that you actually get normalization of that sodium. And if you've got a high sodium level in a hyperglycemic patient, they are so crispy, like really hyperosmolar. Can anyone think of another iatrogenic cause of hyperosmolality, which might cause hyponatremia? A medication that we administer?
Diuretics? Will they do it?
Ah, interesting. Are they hyperosmolar though?
No, probably not. So not.
I think they're probably hypo.
Yeah.
With hypovolemia.
Mm.
What did you say, Bron?
I was going to say the same thing.
It's actually a medication we give to patients with increased intracranial pressure.
Oh, mannitol.
Mannitol.
But then that's a diuretic.
Sorry. You're right. Why is it a diuretic?
Is it?
What else does it do?
It sucks the water out of the cerebral.
Because it's hyperosmolar. Creates hyperosmolality.
Yeah.
So it draws water into the space it's in. So initially it'll draw water into the vascular space, and then it will draw water into the filtrate, urinary filtrate. So that's how it ends up being a diuretic. But first, it's something that you use to increase osmolality. So they're kind of the only two causes really of a patient with low sodium and high osmolality. So then if you've looked at your bloods, glucose is normal, sodium's low. What situation would you see this in most commonly, do you think?
Addison's.
Good. Yeah. And what will the osmolality be high or low with Addison's? Low, did you say?
I'm thinking maybe not, doesn't necessarily have to change, does it?
It's probably low because
No.
it's a primary sodium loss, and that's the main driver of that osmolality. So it usually the sodium gets lost and the osmolality is like, oh, how am I going to correct this? I can't retain my sodium. And then eventually the urea goes up because of their renal perfusion getting so bad, but that's like not going to be enough to balance out that osmolality. So they're usually low. So what about if we're talking about a hypoosmolar hyponatremia? We can divide that into 3 categories. So hypervolemic, normovolemic, and hypovolemic. So if they've got low volume because they've lost their sodium, so Addison's is one example of that. What's another example of that? What about 1-year-old Labrador, ate a tennis ball?
Profuse vomit, yeah, gastric vomiting.
Yeah, so losses of sodium can be either urinary or gastrointestinal pretty much. Where else do we sometimes lose sodium? Rare, like it's quite a sort of neat specific example, but this is the category diuretics would fit in, just FYI.
Oh, third spacing?
Third spacing, good. What's a third space?
Like your cavities, pleural cavity, abdominal cavity, pericardial cavity.
Yeah. So I think probably the only time I really see this is in dogs with chronic right-sided congestive heart failure, and they get their ascites drained regularly as part of their therapy.
Yeah.
Actual clinical hyponatremia. And then the other place you can lose it in is potentially cutaneous. So but is much more significant for humans because they sweat, but burns and stuff like that, you can lose sodium and become hypoosmolar and hypovolemic. Sorry, I've had a request. So if we kind of look at, you've got a hyponatremic patient, hyperosmolality, normal osmolality, or hypoosmolality, and in hypoosmolality, hypovolemic, normovolemic, hypovolemic. They're my categories, right? So we've talked about hyperosmolality. We've talked about hypovolemic, hypoosmolality. This is getting confusing. Sorry. What about, can anyone think of a reason why a patient might be hypoosmolar with a normal volume?
Retaining free water.
Pardon? Say it again, Jen.
I said for retaining free water, but I was sort of talking to myself out loud. But
Yeah, you're exactly right, actually. It's pretty much the only way that they can, either retaining free water or being iatrogenic administered hypotonic fluid.
Would it be like what about the polydipsia? Like psychogenic polydipsia?
Exactly. So the only way that you can lose sodium but actually retain normal volume is if you're replacing your losses with a hypotonic solution. So for example, in a human, if you ran a marathon and then didn't drink any electrolytes, you'd end up normovolemic eventually, but you'd be hyponatremic. In a dog, same thing. If they
what time are you back?
Psychogenic polydipsia, like you said, there's a hypothyroidism, that mixed edema that they get with hypothyroidism. That's one of the causes, but there's like, it's not necessarily obvious, but that's probably not going to be the thing you're most concerned about. And actually a syndrome of ADH, inappropriate ADH secretion. Has anyone heard of that?
It's associated with head trauma typically. I think SIRS and sepsis can trigger it as well.
Yeah,
but particularly head trauma.
Yeah.
And so they're oh, sorry.
You do. You go.
I was going to say that they you inappropriately excessively secrete ADH. So if you're excessively secreting antidiuretic hormone, that's what puts your little aquaporins in your collecting duct to retain water. So you could have excessive free water retention.
Excellent. So that's so annoying. Sorry. Slow down, please. Snippy. Slow down. Good. Excellent. So then what about hypervolemia? When are we going to be hypoosmolar with increase in volume?
Iatrogenically, if you've accidentally, if you're giving your patient like excessive volumes of D5W or water for injection.
Yeah. Excellent. And what about
Will HHS do it?
what's HHS?
What is that? Hyperosmolar,
Yes.
not the diet.
Hyperosmolar syndrome.
Yes.
Hypoglycemic, hyperosmolar syndrome. That's a very good question. I think that's going to fall under the hyperosmolality section.
Because you're hyperosmolar.
Yeah,
Yes.
so we're in the hypoosmolality, but you will potentially be hypervolemic eventually with start hypervolemic, and you might end up hypovolemic with that. What organ do we require to be functioning to excrete free water?
Kidneys.
Yeah, excellent. So what situation clinically would we be quite nervous about causing hypervolemia?
Oh, fluid overload? Like is that?
Which one?
Oh, sorry. You go, Maya.
Oliguria.
Yeah, oliguric or anuric renal failure. So they've lost the ability to balance their sodium and water. So they can't excrete. There's nowhere for that water to go once it's in the system. And there's places for the sodium to go, but the balance is going to be out. So they often end up hypervolemic and hyponatremic. What about a disease that we use diuretics for all the time?
Heart failure.
Failure.
Heart failure, yeah. Why do we use diuretics for congestive heart failure?
To withdraw the fluid out of the lungs.
Because they're
A
hyper.
third spacing.
Yeah. Yes. Why is there fluid in the lungs? It's getting complicated and off topic.
High pressure in the capillaries of the lungs.
Why is there high pressure in the capillaries of the lung? What's the so
Atrial pressure will increase, which will then cause the backflow.
yes. Why is atrial pressure increasing?
Because of the most common in small animals is the valves, because of the valvular disease causing a leak, which then backflows and then
Yeah. So when you've got a valve, you've got a leaking valve in the mitral valve, and your heart's pumping, and half of the blood's going out the aorta to the kidneys, and half of it's going back through the leaky mitral valve, and so the renal perfusion drops, and then what happens?
RAS.
RAS, exactly.
RAS, exactly. And what's the effect of RAS?
Sodium retention.
Sodium and fluid retention. So they end up hypervolemic. So dogs in congestive failure, B2 congestive failure, where we've got that remodeling, are hypervolemic. Has anybody ever seen a congestive heart failure dog that's hyponatremic and hypervolemic with water dripping out their nose?
So a cat, but that was like end stage.
It's end stage, yeah. So hyponatremia in congestive heart failure is a very strong negative prognostic indicator. So that, yeah, it's if I got a hyponatremia and they were in fulminant heart failure with water flooding out their nose, I'd probably say 50-50, if that, even with intensive management. Good. So does anybody want to tell me the categories of hyponatremia to review?
Hypoosmolar, hyperosmolar, and normal osmolar.
Good, exactly. And then in hypoosmolar, what are our other categories?
Hypovolemic, normovolemic, hypervolemic.
Yes, so nice. So now when you see a hyponatremic patient, I want you to go, ooh, euvolemic, hypovolemic, hypervolemic on your exam, because it's really going to help you then say, okay, I think I know where the sodium's going or why the sodium's low. So we didn't really talk about normal osmolality and hyponatremia. So what might cause that? How can you have a low sodium?
Well, when you've got other other anions taking its place.
Hmm.
And I just can't think off the top of my head that situation.
If you're giving fluids that are low in sodium. that's
Yeah,
possible.
so that would be in hypoosmolality typically, rather than normal osmolality. It's a little bit of a trick category, in that I don't really know why the osmolality stays normal when the sodium's low, but hyperproteinemia and hyperlipidemia are two diseases where we see the osmolality being normal and the sodium being low, not uncommonly. But I don't really understand the mechanism of that. But it's just something, if this dog's like, if you've got a dog with a triglyceride of 25 and hyponatremia, then I'd probably say, okay, I'm probably not going to look into the hyponatremia. I'm going to chase this.
Yeah.
Okay.
What are you defining as hyponatremia? Like what level is hypo for you?
And it's outside the flags. There's different reference ranges.
There
But
is,
yeah.
and that's the thing. Like if it's a mild, do you like even care, or do you care only about? It's not strictly numbers, but kind of numbers to give, like sort of give us a guidance. So,
Yeah.
what number below is that you're like, okay, I need to really look into this more seriously than just like,
Realistically, if I've got hyponatremia, I want to be able to explain it by some other change on the blood work or physical exam. So if this dog's coming with 2 days of acute vomiting, I'm not worried about it. I'm not going to chase it.
Mm.
Yeah. If it's coming with PUPD, I'm probably not going to chase it that hard. I'm going to look into the cause of the PUPD. So hyponatremia is sort of something that we see, but it's very rarely the primary problem. And it would only be if like you kind of exhaust all of those different investigatory pathways and then go, I might be dealing with some sort of SIADH syndrome or something very strange. Yeah. That I'd chase the actual sodium. All right, let's talk about high sodium. When do we see high sodium?
Okay, ingestion from a saltwater swimming pool.
Excellent. So salt toxicity. The one we see, I don't know if it's just like sort of demographic of areas that I've worked, but we see Plato toxicity that's the most common cause that I've seen salt toxicity in. So if we think about our categories of hypernatremia, does anyone have a nice way of thinking about how I'm going to break down what my differentials are with hypernatremia? To do with
Anemia, hypovolemia,
and hypervolemia.
bulimia.
Yeah. So if you've got a salt toxicity, what sort of hydration status would you expect in your patient?
Overhydrated.
Yes. Yeah. Because they're going to go straight for that water bowl, aren't they? After they eat their Play-Doh. What other causes of hypervolemia and do we see hypernatremia in? What happens if you keep a patient on replacement fluids instead of swapping them to a maintenance fluid in hospital?
Yeah.
I reckon that's the most common.
Yes. Iatrogenic.
Yeah. And there's one other syndrome we see in cats, and they don't typically chase the sodium change. It's
oh,
hyperaldosteronism.
yes.
yes. I feel like we need buzzers. Let's make this fun. Yes, exactly. So hyperaldosteronism in cats, the sodium's usually like in the normal range in my experience, but theoretically it could get high. But we're going to be much more focused on that potassium because it's much more clinically significant for the patients. And we see hypertension typically as a result of that hypervolemia. So that's my hypervolemic category of hypernatremia. What's another cause of hypernatremia?
Loss of free water.
Hydration.
Excellent. So what would their hydration status be?
Hypovolemic.
Hypovolemic. Perfect. Yeah. So typically, like pretty much anything that causes dehydration, eventually the body will say we can't lose any more sodium, and you've just lost water. You just lose water. So we could. Where else? Where can we lose fluid? Free fluid in the body. Renal. Somebody said renal.
I guess you can get tissue edema if you have.
Yes.
Yeah.
Yep. Perfect. And then one more place.
Dead spacing.
Two more places. Sorry. That's
Panting, is that free water?
which one?
Panting?
Oh, it is. They'd have to do a lot of panting. But yeah, we should have respiratory on there for sure. GIT is the one I was thinking of.
Oh,
Yeah.
Yep, water balloons.
And it's not really free water that they lose, because obviously there's electrolytes depending on the way that they lose it in there, but they can end up hypernatremic with water loss from gastrointestinal causes, right? We've seen that before. So I tend to sort of divide in my hypovolemic animals if I got renal losses or if I got extra renal, so like gastrointestinal. And can I explain it easily on my history and physical exam and the rest of the bloods, or do I need to go and chase like whether it got into its own as diuretics or something? And typically you've got polyuria if there's renal losses, right? Okay, let's talk about a normovolemic hypernatremia. Can anyone think of any causes?
Oh, maybe like what about tick envenomations? Because they don't have a gag. We don't let them drink water. So then like volume wise, I think they may be okay because they're not necessarily dehydrated. Because maybe we're giving them fluids as well. But they can get hypernatremic, can't they?
They can, yeah. So decreased water access is one of the causes that's listed of hypernatremia with normovolemia. And I don't really get it.
Because I had a case last year like that. It was a tick case, and obviously that was the first time I saw, and the sodium was climbing and climbing, and then reached to 174, and I was like, I don't think I should just sit on this anymore and do something.
Yeah, we're gonna need some fluids in here. So eventually they're going to get hypovolemic, right? So there might be a period where they get hypernatremic and then their body's going to not be able to compensate anymore and they'll get hypovolemic.
I suppose like maybe if they're still eating, say for example, and they're getting kind of salty food, but they're not drinking for some reason, although I can't think of a reason why that.
Yeah, so it's kind of like they've got a salt tox without the hydration. Yeah. What about a patient that's got compensated losses, like a patient that's drinking, like a polyuric patient that's drinking free water to keep up? They shouldn't be hypernatremic at all, should they? They should be hyponatremic. Yeah, because they're replacing solute-rich fluid with free fluid. So that, because the other thing I've got in my list from the textbook is diabetes insipidus. So in theory, if you're losing with DI, you're losing free water. So you could drink free water to keep up, but you might end up hypernatremic. And then you lose all your like medullary hypertonicity and stuff like that. So it might then impair your ability to reabsorb water even by the normal mechanisms.
Yeah, so what about like a post-obstructive diuresis? Would that?
So they typically hypovolemic. Well, I've got that in renal, like hypovolemic, hypotonic fluid loss. But yeah, in theory, like all of these categories, I feel like they start normovolemic and then they become hypovolemic. So you could almost think of them as a spectrum of like loss versus ins and outs. Excellent. Okay. Are we happy with sodium?
Sodium's a headache.
Sodium's a headache, especially the hyponatremic patients. I find that the correction of hyponatremia stresses me out.
Yeah.
Never goes according to your calculation. Oh, hi, Matt. Sorry, I just saw you. Okay, so I'm busy cheating with my notes, so I'm not looking at the screen. Okay, should we talk about potassium or calcium next?
Potassium.
Potassium. It goes with sodium.
It does. Agree. Yeah. Okay, so who wants to tell me? Ooh. Where is? Tell me how potassium impacts aldosterone impacts potassium.
It causes the kidneys to shed potassium.
Good. Excellent. Do we know how?
No.
Was it the increased activity of the sodium potassium pump?
Good. So the sodium potassium pump sits on, so if you've got, this is your, over this side of my hand is the renal tubule. In the middle here is my tubular epithelial cell, and over here is my interstitium, okay? So we've got sodium potassium ATPase pumps on this surface, pumping all the sodium out of the cell into the interstitium to then get sucked up into circulation. So it's actively decreasing the sodium concentration inside the cell, which means that our concentrated filtrate is the sodium in that is going to flood into the cell passively down its concentration gradient, and then it's going to get pumped out again. So we've got the same thing happening in reverse. So the sodium is getting actively pumped out and the potassium is getting actively pumped in, and it's going to go the other way. And a whole heap of the acid-base balancing equations mean that the potassium gets shafted out and the sodium and hydrogen get pulled back in. So there's sort of the two, it mostly is dependent on sodium. So we usually get sodium changes as well as potassium changes. But because that range of normal potassium is so much narrower than the range of normal sodium, we actually see clinical effects of changes in potassium much more than we see clinical effects of sodium. Make sense?
Mm.
So let's talk about hypokalemia, because I think we just see it all the time. Does anyone have nice categories for hypokalemia? Thinking about it when you see it? So where can potassium go in the body? Or why could you get low in potassium? Let's say that.
Losses or shifts?
Good. And then one more.
Well, a feline aldosterone secreting tumour.
So that's going to cause losses. So losses, shifts, or anorexic cat.
Decreased intake.
Decrease intake. Yeah, they're the three. Yeah. So decrease intake is obviously like something that we just see all the time, right? And that's, I feel like a lot of the time we see a low potassium and just go, they haven't eaten for 3 days. But we should also consider the other causes of hypokalemia in that patient according to the other stuff that's going on. Particularly
in cats, isn't there a, what is that breed? The Burmese.
Burmese.
You know what I'm getting at, but
Yes.
can't say it.
Yes. Has anyone ever seen that?
No. It's a mutation in some gene, right? Like W something K or something like that.
Oh my God. How
It's
do you
just,
remember that?
but I can't say it properly, so I don't remember it completely. There's just something in my head, but not quite it.
WNK4 gene mutation.
Yeah.
I'm looking at my notes. There is no way I ever would have known that. Literally, like even at my smartest. It was amazing. So Burmese cats get this genetic mutation, and they're actually, they're not affected from when they're baby cats. So they can be like 2, 3, 4 years of age, and then all of a sudden become profoundly hypokalemic. And it's essentially potassium regulation in the distal nephron, where it's really like everything gets balanced out and it's the last chance to get balanced out. And essentially this gene mutation means that that potassium regulation mechanism doesn't work. So all the potassium just gets lost in the urine.
That's renal.
Do you know whose cat had this? The only case I've ever seen.
John Colvin.
Yes, exactly. Version. Yeah. So you'd never want to be owned by a vet or vet staff. Yeah, so which category of hypokalemia would that go into?
No,
Sorry?
should be euvolemic.
Oh, sorry, we're going to go decreased intake, intracellular shifts,
Loss.
or increased losses. Yeah, so it should be increased losses.
Loss.
Good. So let's talk about other causes of losses of potassium. Why do we lose potassium? Where do we lose potassium?
GI renal.
Great. They're the two. Perfect.
Third spacing again.
Third spacing. Do we lose potassium into the third space?
Well, sometimes when I have had like either pleural effusion or mainly pleural effusion and potassium's low, I've just said, oh, it's because probably, but I don't know if that's the right thought.
Yeah. I don't know. I would need to look into that because I always think sodium and water for sure.
Altogether.
I'd be more likely to write off a hyponatremia with an ascites patient than a hypokalemia. I'd be like, oh, is it because you haven't eaten, or is there something else going on? I can't actually think of why that is, but I'm sure.
Because potassium's more intracellular, right? So unless you were getting lots of like,
yeah, cell rupture.
But like just the shifting, like
hypotension.
what is extracellular shifting? Like what exactly does that actually mean?
What is extracellular shifting?
Or transcellular shifting, sorry, not
I mean,
necessarily extracellular.
Do you like third space versus extracellular fluid?
Oh, I see what you mean.
So if it's like translocation from like drug therapy, extracellular translocation, I don't think that means like it's going to end up in the third space as ascites. They're kind of different.
Yeah, I see what you mean.
Departments.
So let's park that and talk about it when we're talking about the transcellular shift category. And while we're talking about increased losses, so GRT renal, what about how do we lose, where does potassium go in the GRT? Why is it low in vomiting dogs?
Because they're vomiting it.
Are they? Where is the potassium in the stomach?
That's a good point.
it's in the duodenum. So that isn't it. Sometimes if they've got an obstruction or something and you're getting losses like from the small intestine coming back up or something, is that making that up?
It's a really interesting thing that I've just struggled to get my head around. So there's not actually
intake.
Well, yes, that's definitely going to be a factor. So you're not going to be able to compensate when you lose it. So what actually happens is what's the juice in the stomach? What are the electrolytes in there?
Bicarbonate.
Chloride.
And hydrogen ions,
Hydrogen
HCl
ions.
essentially.
Yeah, exactly. So we can explain our chloride losses, right?
Mm-hmm.
And then all of a sudden we're losing hydrogen, we're losing chloride. I did say don't ask me about acid base, but we're going there, sorry. So the body's then going to try and retain hydrogen in the kidneys at the expense of what?
Oh, potassium.
Potassium.
Good, exactly. But then we're also going to get disruption of our NAK, ATPase pumps and things because we're trying to retain sodium, because we're also hyponatremic. So there's a couple of mechanisms of hypokalemia in vomiting patients, but it's not actually
Gut loss.
Gut loss. Yeah, exactly. But it's a vomiting dog, you get hypokalemia for sure. So that's I just want to highlight then what Simone said with the like proximal GRT obstruction. If I've got an acutely vomiting dog and I've got sodium, excuse me, sodium, potassium, and chloride all low, I'm pretty much going to surgery. Unless endoscopy is an option and I want to like see whether it's pyloric or duodenal kind of thing. So that's it. There's not that many things that cause all three electrolytes to go down. It's a really nice kind of marker. Okay, what sort of renal losses do we see? Why do we lose potassium when we have renal disease?
Well, Well, apart from renal disease, I've seen it in chronic diabetic ketoacidosis, where there's the kidney is constantly excreting potassium because of the high levels, and you end up total body depleted.
Yeah. So that's a really nice combination of transcellular shift mechanism as well as renal losses. And you're exactly right. Diabetic patients are really prone to hypokalemia because of their medullary washout. So they end up with such a high tubular flow rate, and a reabsorption of potassium is dependent on the filtrate moving through the tubule quite slowly. The mechanisms required to reabsorb potassium require slow moving urine. So if you've got polyuria, you end up with losing some of your retention capacity. So your kind of fractional excretion of potassium will be higher. And then you get medullary washout on top of that, which further increases the volume moving through the tubule and the speed that it's moving through. So obviously this is the mechanism we see in any patient with renal dysfunction, whether we've caused it with giving diuretics or whether they've got renal dysfunction due to nephron loss or whatever it is. They can't reabsorb that potassium because it's moving too fast through those nephrons.
Post-obstructive diuresis.
Exactly. That's exactly that example. Like that urine is moving so fast through those tubules, the potassium's gone.
Yeah.
What about the example we talked about with hypernatremia in cats that are hypervolemic?
Hyperaldosteronism.
Yes. So that's one of the other causes of renal losses, which isn't tubular flow rate dependent.
Yep.
And
what's the mechanism in Cushing's?
Oh, of polyuria and polydipsia or of hyponatremia?
Of hypokalemia.
Oh, hypokalemia. It's increased losses.
Yeah.
Yeah. So they've
like
got
medullary
increased tubular
washout
flow
as
rate.
well?
Yeah, increased tubular flow rate, medullary washout. And there's something else. They don't typically have hyperaldosteronism. Oh yeah, no, I can't think of any other mechanism. Okay, so that's our increased losses. What about our transcellular shifts? What's the most, somebody's already said it, diabetes is the most common cause of potassium shifting. Why does the potassium change with diabetes?
Because of the insulin. Oh my gosh. Yeah. I can't remember when glucose moves into the cell, potassium moves out. And if when you're treating, I can't remember. When you're correcting hypoglycemia, that's when you get the transcellular shift. Is that right?
Yeah, so it's actually the glucose transporter, I think.
Exchange with hydrogen as well, isn't it?
Oh, so there's definitely acid base component to that potassium shift for sure. So if you've got an acidosis, you'll definitely get shifting with the potassium. But let's just, with the glucose transporter, glucose is actually transported into the cell with potassium, typically.
Yeah.
So if you've got your glucose stuck in your bloodstream because the insulin hasn't provided the key for the glucose to get into the cell, the potassium is also stuck in the bloodstream and it gets excreted in the kidneys because it can't get in. So you end up with a total body depletion of potassium. And then
we give insulin.
Then you give insulin, yes. And then where does your potassium go?
Into the cell.
Into the cell.
Into the cell with the glucose. In it goes. And what happens to our blood potassium levels?
Crashes.
Oops.
Yeah. So if you've got a normal potassium level in a sick diabetic patient and they're hypovolemic, supplement your potassium from the beginning. Okay, so back to the hydrogen. How does potassium and hydrogen interact?
There's an antiporter where
That's more advanced than I was thinking.
is it if there's too much hydrogen,
Mm-hmm.
the acidosis, then hydrogen will go into the cells in exchange for potassium coming out of the cells.
Exactly. And then where does the potassium go?
To the urine.
Yeah, exactly. You lose it. So once it's come out of the cell, you've got to replace it.
Right. Makes sense.
Very demanding dogs today.
Cool.
Okay, let's do some hyperkalemia. Is everybody happy with that? Decrease intake, interest or transfer shifts, and increase losses. So if we then flip that around and say hyperkalemia, what are our categories?
Decrease excretion.
Yeah, great.
Transcellular shift,
Yeah, and
increased intake.
Intake.
yeah, it's got to be iatrogenic.
Yeah,
like it's just if you've supplemented too much, basically. So let's just not talk.
Can it also be artifact, like pseudo hyperkalemia? Like the cell, it can translocate out of the cells post collection.
Oh, yeah, for sure. That's a really good category, actually. We used to see that a lot. A clinic that I worked at was really far from the lab. And when we collected bloods to send out, we quite often would have a hyperkalemia when we got it back just because cells had broken down. That's a really interesting category, actually, because there's other Akitas.
Yeah, sharp, like Japanese breeds.
Yes.
Sharpei, Shibas.
Yeah. They've got more red cell fragility. So if you submit whole blood without spinning it, their potassium will measure high because more of their red cells will have broken down than would be normal, kind of thing. And
the same applies if you've just got marked hemolysis as well, right?
Yes. Yeah, exactly right. Yeah. Or traumatic blood collection and stuff like that if you've got cell lysis.
And like with the pseudo one, also like severe thrombocytosis will cause it, right? Because
yeah,
I know thrombocytosis.
White blood cell count as well, I think.
Yeah, interesting. Yeah, I don't know about the white blood cell count and thrombocytosis, but having more cells in the whole blood that you've submitted makes sense. Like if they're
IDEX have told me that.
Yeah, cool.
I think platelets release potassium while clotting. That's why.
Oh, cool. Interesting.
Not 100% sure. Double check or whatever I say.
I think that was my understanding as well.
Yeah. Oh, cool. Okay, let's talk about translocation. So if acidosis causes potassium to go into cells.
Oh, doesn't it cause it to
wait, causes it to come out of cells. Yeah. Then what we talked about with hypokalemia, we should have talked about in hyperkalemia. Sorry.
I was wondering.
Yeah, alkalemia
Alkalosis
causes hypokalemia, whereas acidosis causes hyperkalemia. But in reality, they never really get hyperkalemic because they weigh it out before they get.
right.
So total body potassium will drop, but what you see in the blood will increase. Is that right?
Yes. Yeah. So it will look normal, but it will actually do that. What about clinical syndrome that we see sometimes? Horses get it, greyhounds get it.
Oh, lysis. Like muscle.
Yeah.
Mild.
And is there another situation where you might see like a sudden cell lysis?
Tumor lysis syndrome. I haven't seen it though, but just theoretically.
You've seen it. I've seen it once as well, and the dog only got pred. Like,
how did you know it is that though? Like what was the?
Because I just played Snap with the symptoms on Google. And that ticked all the boxes.
Yeah, I think ours had just had a dose of chemo and came in. Yeah.
Lymphoma is known to do that because lymphoma suddenly will.
So many cells.
This was lymphoma too.
And it's so chemo responsive typically as well. This dog had it was well. We started. Oh no, it wasn't well. It had lymphoma, so it had ridiculously huge liver, huge number of neoplastic cells. started on pred, came in the next day with like raging hyperkalemia.
I mean, you helped its cancer.
Very effective. Yeah. Excellent. So the other situation we see in sometimes is weight animals. So when they've had like an infarct and had like they've got to lose a lot of tissue before you get a systemic hyperkalemia. Can you hear my dogs? Is it just
No.
But
one of them sings.
We like thromboembolic events, yes. What about thrombosis? Just thrombosis, like aortic thrombosis.
Oh, yeah. No. So cats get aortic thromboembolism.
Mm-hmm.
Dogs
Whereas
get
dogs
aortic
get
thrombosis.
Yeah.
Dogs are very good at recanalizing or diverting blood flow. So dogs are often with, I don't know if you've ever seen aortic thrombosis. I think I've seen about 6, and they're all walking. They're weird gait, but they're all ambulatory. Whereas cats are like outright. Yeah. And the other thing is thrombosis develops like, it's not like you don't cut off the blood supply like that. It builds. Yeah. So they've got an opportunity to kind of redirect the blood flow. So yeah, I don't think I'd be surprised. But also might write it off if it popped up on my blood test. Okay, what about decreased losses of potassium? What might cause that?
urinary obstruction.
Oliguria.
Oliguria, excellent. Yeah.
Obstruction.
Yeah. Good. That's, I reckon, the most common one clinically that we see. What about a dog one?
Like uroabdomen.
Oh, yeah.
Addison.
Addison's good. Yeah.
Whipworm?
Whipworm. I love that. Has anyone ever seen?
Unfortunately not, but I feel like I always hear about it as pseudo Addison's.
Yeah.
I never see it.
Something you read about. I had a dog that was like screaming Addisonian on blood tests, and I ultrasounded and I had worms in its intestine. And I was like, oh yes, this is like one of those unicorn cases. It wasn't, it like tested negative for whipworm. I was like, damn it. And the stim test was like 230. I was like,
I've seen it too.
You've seen it?
I've seen it too. Yes. In fact, I've got a picture through an endoscope of riding whipworms in a colon.
Oh, that is a cool case.
But most of the cases I saw it in were sort of sheepdogs that had lived in the same hollow log as their ancestors for
and
100 years.
Yeah. Yes, that's still, I think it's still on my bucket list. I still think that maybe the fecal test was negative. It was like false on that dog. But,
yeah, well, the whipworms are not very good shedders. They have their on days and their off days, so you can't rely on one.
Yeah. I did get them to pull the poo sample.
I think it has to be like an afternoon sample, not a morning. Well,
when
I was working at Taronga Wildlife Hospital, the pathologist was always like, get afternoon samples for parasitology, you don't get morning samples.
Why?
Why?
Because that's when they don't shed in the morning, apparently.
Wow.
The whipworm sleeps in.
The worms
Like,
have a rhythm.
parasites just aren't like shedding.
They're not morning
Lazy worms. Oh. Sorry. Excellent. So that's pretty much the main. Sorry, it made me laugh. The main causes of hyperkalemia. So with sodium, we want to like look at the osmolality and look at the volume. Whereas with potassium, we want to look at where potassium goes in the body to then get to the bottom of what the causes are. Let's go on to calcium, which is probably where I don't want to spend too much time on calcium because we cover like in endocrinology, we cover calcium homeostasis and disorders of parathyroid hormone and stuff. But I did actually see a cool case a couple of weeks ago. I just got called in to look at a dog who had like 2 kind of collapse episodes at the dog park. And it was a border collie. No, it wasn't. It was a Kelpie, sorry. It had been chasing the ball. So it had been doing very intense exertion, and it kind of like the owner kind of described it, just went really tense and then lay down. Yeah. And they did some bloods, and the calcium level was like 0.8 or something like that, a total calcium. It was really low. And then when you look back at this dog's bloods over the years, it was kind of like 1.44, 1.2, 0.8. So it had been low for like 3 years. And then we're kind of like, well, this is just this dog's normal. And we tested its ionized calcium. It was really, really low. And I didn't find any other cause of the kind of collapsing cramping episodes. And it's actually a hypoparathyroidism. And it's actually the 4th Kelpie I've seen in Sydney.
Oh, wow.
Hypoparathyroidism. So I just wanted to mention that case because it's interesting if other people are sort of seeing Kelpies with weird exercise intolerance. So why would well, first, why does hypoparathyroidism result in hypocalcemia?
Because can't like nutritional secondary hyperparathyroidism also result in decreased calcium?
Yes, yeah. But there's they've like whole bodies run out of calcium in that situation. Like it's just used it all up. So if they don't have calcium in their diet, they don't have enough intake, they're going to just draw on all their stores. So PTH is going to be very active in trying to increase the calcium. So we're going to get decreased intake, decreased absorption. PTH is going to say, I need to like absorb more from the intestines, get more out of the bones to maintain this. So PTH level is going to be high. Whereas in this dog, he had very well, like responsibly manufactured diet, no calcium deficiency intake, and actually X-rays, he didn't look hypocalcemic. Like he didn't look like he'd taken it out of his bones. Yeah, exactly. Why would he not look like he'd taken it out of his bones? What
he does have the parathyroid to make it.
Yes. Lovely. Excellent. So why was this dog developing this disease over 3 years? Why did he only just start? So
was it like an autoimmune parathyroid attack?
Yep. So his parathyroid level probably went. Why? What other mechanisms might have helped him maintain that calcium level at an acceptable level for a while?
Got calcitriol as well, which works synergistically with PTH, but also increases your resorption of calcium.
Exactly.
In your gut and resorption in your kidneys.
Yeah. So there's a few other mechanisms that help maintain calcium levels. So really the only situation that we see calcium levels plummet in is after we remove a functional parathyroid adenoma, and the calcium level goes down really fast, and we see all these symptoms that we're seeing in this Kelpie of like kind of muscle cramping, a little bit of GIT disturbance. What other symptoms of hypocalcemia has anybody seen?
Twitching.
Yeah.
Facial pain.
Yes. They get pruritus on their face. It's so interesting. I literally had a dog waking up from a parathyroidectomy going like this. Was so irritated by it. What's another situation where we see acute hypocalcemia?
And female dogs like after birth.
Lactating, yeah.
Eclampsia.
Yeah. Yeah. And they just haven't had time for those compensatory mechanisms to kick in. And they're so reliant on gastrointestinal absorption that if they're not then on a good quality diet and have the stores already to draw on, then they can't keep up with that requirement. So
it can happen too if they're over supplementing calcium during pregnancy.
If they're over supplementing.
Yeah, because they shut down the parathyroids.
Interesting.
You need to ramp up after whelping.
Yes.
Yeah.
Oh, so cool. Yeah. It's not even on my radar. And I just wanted to raise that case just because we often talk about hypercalcemia, and I think we talk about it a lot. But yeah, hypocalcemia is a lot more subtle clinically, a lot more gradual, and it's definitely if you see a low total calcium. What other causes of low total calcium might you see on your bloods?
Hypoalbuminemia.
Right. Excellent. So vast majority of the time, your calcemia is like spurious, right? Or not significant when you see it on bloods. But yes, in this case it was.
The formula for that, is that reliable?
Formula for what?
Calculating the calcium related to albumin.
I think I read
No.
about it and no.
Yeah.
I thought it wasn't reliable, actually. What I'm asking.
Yeah, that's my impression as well from my reading. But having said that, I always eyeball, like if I've got a low total calcium and a high normal albumin, I'm thinking, oh, that's a bit off. Like it just does rate, like I wouldn't draw any conclusions without doing an ionize, but it does raise alarm bells.
Acute pancreatitis will cause hypocalcemia. Saponification?
Yeah, great. Excellent. So calcium gets caught up in the fat that's kind of necrotic. And what does saponify mean?
Soapify.
Yeah.
Makes
Soap. Yeah. It's made into a soap. So you know how they make fat into soap? Like that's where soap comes from traditionally? Yeah. That's what's happening in the pancreas. And it just absorbs all that calcium. Or shouldn't say absorbs.
Binds.
Bind, kind of.
Fine. That's the word. Yeah.
Do you ever see that? Like, can you see that in ultrasound, like mineralization?
Oh, it's not actually, it doesn't become mineralized. It just like little molecules of calcium change the fat
Yeah, okay.
and
Okay.
turns it into soap.
Does that, are they ever clinical for the hypocalcemia?
No. But it might be a ionized hypocalcemia. It's the only clinical significance is it's a negative prognostic indicator. So if they've got low calcium, it's kind of, it's pretty severe fat inflammation. Yeah. All right, we might have to call it and not go into hypercalcemia. But that was fun. And I'll see you in 2 weeks for another tutorial called we're analyzing fluids.
Oh,
Mm.
no.
Yeah, fun.
As
Okay.
in where to buy them?
Sorry?
As in where to buy them?
No.
No, the shortage is like, oh
That would be
God.
hard at the moment. Hey.
Yeah, that's way beyond me actually. Excellent. All right, I should say we're analyzing body fluids.
Yeah.
Oh, right.
Not like
Not
talking about
looking at
all right, thank you so much, guys.
Thanks, Anna.
Thank you, Anna. Have a good day.
Bye.
Good day, guys.
Thanks,
Bye.
Bye.